Hey everyone, welcome back to the channel. Grab your coffee, your highlighters, whatever gets you in the zone. Because today we are diving headfirst into antimicrobial agents. And trust me, this is one of those high-yield topics that shows up everywhere on your exams and on the wards. I'm Professor Shaibu Oricha Bello, and I drew this whole thing out on the board the way I teach it in a real lecture hall. My promise to you is simple. By the end of this video, the mechanisms, the drug classes, the side effects, and yes, the mnemonics are all going to click and actually stick. This is pitched at the preclinical level, so we're building from the ground up. No prior memorizing required, just bring your curiosity. Let's get into it. Alright, before we sprint, let me show you the map of where we're going, because antimicrobials can feel like a giant pile of names until you give it structure. We're going to start with the core principles: cidal versus static, spectrum, and selective toxicity. Then we march through the drug families by their target: cell wall inhibitors like penicillins and cephalosporins and vancomycin. Then the protein synthesis inhibitors that jam the ribosome. Then the nucleic acid inhibitors like the fluoroquinolones. After that we hit the folate antagonists, sulfonamides and trimethoprim. Then a grab bag of special agents plus TB therapy, the famous RIPE regimen. We finish strong with resistance and stewardship, how bacteria fight back, and then a one-page mnemonic cheat sheet that ties the whole lecture together. 8 stops on this tour. Keep this roadmap in your head, because every drug we meet is going to slot neatly into one of these buckets. Let's build that foundation first. Okay? Foundations first, because if you nail this vocabulary, everything downstream gets so much easier. These are the 4 concepts every antibacterial conversation is built on. Number 1, selective toxicity. This is the whole game: kill the bug, spare the host. Antibiotics work by hitting targets that bacteria have but our human cells do not, things like the cell wall, the 70S ribosome, and folate synthesis. That's why they can poison bacteria without wrecking us. Number 2, spectrum, narrow versus broad. Narrow spectrum hits a focused set of organisms like a sniper. Broad spectrum takes out many gram positives and gram negatives at once like a shotgun. Both have their place, and broad isn't always better. Remember that for stewardship later. Number 3, cidal versus static. Bactericidal drugs kill outright. Bacteriostatic drugs just halt growth and let your immune system finish the job. Hold on to that distinction, because the very next slide is all about it. And number 4, MIC and MMBC, how we actually measure potency. MIC is the lowest concentration that inhibits growth. MBC is the lowest that actually kills. These numbers guide how we dose. Lock these 4 in and you're speaking the language of antibacterials. Let's zoom in on cidal versus static, because this is the kind of distinction that separates a good answer from a great one on exam day. Bactericidal means the drug kills bacteria outright, and we reach for these when the host genuinely can't clear the infection on their own. Think endocarditis, meningitis, or a neutropenic patient whose immune system is on the floor. The classic killers: Beta-lactams, vancomycin, aminoglycosides, fluoroquinolones, metronidazole, isoniazid, and rifampin. Our bacteriostatic means the drug just slows replication down so the immune system can catch up. That's perfectly fine for a milder infection in a patient with an intact immune system. Most of the protein synthesis and folate drugs live in this camp. And here's the mnemonic I want tattooed on your brain, where EC stati about being static, erythromycin and the macrolides, clindamycin, sulfonamides, trimethoprim, tetracyclines, and chloramphenicol. That's your classic bacteriostatic crew, the ones that inhibit rather than kill. Say it out loud, EC static, and you'll never mix them up again. Now here's the big picture, the slide I'd frame and hang on the wall, because this single idea organizes the entire lecture. Every antibacterial drug attacks one of 5 targets. That's it. 5. Target 1, the cell wall, where drugs block peptidoglycan cross-linking. That's your beta-lactams and vancomycin. Target 2, protein synthesis, where drugs jam the 30-ras or fetus ribosomal subunit, your aminoglycosides, tetracyclines, and macrolides. Target 3, nucleic acids, where drugs inhibit DNA gerase or RNA polymerase, your fluoroquinolones and rifampin. Target 4, folate synthesis, where we starve bacteria of the building blocks for THF, your sulfonamides and trimethoprim. And target 5, the cell membrane, where drugs literally punch hole in it your polymyxins and daptomycin. Here's my challenge to you. Every time we meet a new drug for the rest of this video, pause and ask, which of these 5 targets does it hit? Get that reflex going and you'll never feel lost. 5 targets, 5 families of attack. Let's start knocking them down one by one. First family up, the cell wall inhibitors. And we kick off with the rock stars, the beta-lactams. I call them the cross-linking saboteurs, and here's why. Every beta-lactam shares that signature beta-lactam ring, and that ring is a molecular imposter. It mimics the building block bacteria use to construct their cell wall. The drug binds the penicillin binding proteins, the transpeptidases, and blocks peptidoglycan cross-linking. The result, a weak, flimsy wall. The cell swells, water rushes in, and it bursts open by osmotic lysis. That's bactericidal killing in action. Their great enemy, beta-lactamase enzymes, which bacteria use to crack that ring wide open and neutralize the drug. Remember that villain, it's going to come up again and again. The beta-lactam family has 4 members. We'll explore the penicillins, our natural and extended spectrum workhorses, the cephalosporins, with 5 generations of broadening coverage, the carbapenems, our big gun broadest spectrum agents, and the monobactams, basically astrionum, which covers gram-negatives only. Let's break each of these down. Let's get specific with the penicillins, because there are 4 subclasses and each one has a job. I want you to think of it as 4 jobs, 4 tools on the belt. First, the natural penicillins. Penicillin G and 5, these are your go-to for strep, syphilis, and meningococcus. Classic, old school coverage. Second, the antistaphylococcal penicillins, nacillin, oxacillin, dicloxacillin. These are built to resist beta-lactamase, so they handle MSSA, methicillin-sensitive Staph aureus. Third, the aminopenicillins, amoxicillin and ampicillin, which extend your reach into gram-negative territory. And fourth, the anti-pseudomonal penicillins, piperacillin and ticagrelin, your heavy hitters for Pseudomonas and serious infections. And here's the mnemonic for that last group. Take care of Pseudomonas, TCP, ticagrelin, carbapenicillin, piperacillin. One quick caution before we move on. Watch out for hypersensitivity. That classic penicillin allergy that can range from a simple rash all the way to full-blown anaphylaxis. Always ask your patients. Now let's climb the cephalosporin ladder, because these come in 5 generations and there's a beautiful pattern to how they evolve. Stick with me on this trend. It's pure exam gold. First generation cefazolin and cephalaxin, great for gram-positive cocci and surgical prophylaxis. Second generation cefuroxime and cefoxitin, more gram-negative coverage and some anaerobes. Third generation ceftriaxone and ceftazidime, serious gram-negatives and a workhorse for meningitis. Fourth generation cefepime, broad coverage plus Pseudomonas. And fifth generation ceftaroline, the special one that covers MRSA. Here's the rule of thumb that makes it all make sense. As you move up the generations, you gain more gram-negative and central nervous system reach, while the early gram-positive coverage gradually fades until the 5th generation swings back and brings it home for MRSA. Mnemonic time: first gen equals pack Proteus, E. coli, Klebsiella, the gram-negatives even the earliest cephalosporins can cover. And one clinical heads up: some cephalosporins cause a disulfiram-like reaction with alcohol, so warn your patients to skip the drinks. Let's finish off the cell wall inhibitors by going beyond the beta-lactams to vancomycin and a couple of friends. Vancomycin is the star here. Instead of binding the enzyme, it grabs the alanine terminus and physically blocks cross-linking. It's our go-to for MRSA, and the oral form is fantastic for C. difficile colitis. But watch the toxicities: red man syndrome, plus nephrotoxicity and ototoxicity. Then we have the carbapenems: imipenem, meropenem, ertapenem. The broadest spectrum reserve agents are big guns we save for when we really need them. A neat detail: imipenem is given with cylostatin to protect it from breakdown in the kidney, and watch for seizure risk. And astrionam or monobactam, which hits gram-negative rods only. Its superpower: it's safe in penicillin allergy because there's no cross-reactivity. Just remember it has no gram-positive or anaerobic coverage. Mnemonic for vancomycin side effects: not RED, ototoxicity, thrombophlebitis, red man syndrome, and DAR-ES. And remember, red man syndrome is just a histamine from flush, infusing too fast, so slow that drip down and you're good. Family number 2, the protein synthesis inhibitors. Here's the key organizing idea. The bacterial ribosome has 2 subunits, the 30S and the 50S, and our drugs split neatly into 2 hit lists depending on which subunit they attack. On the 30S subunit we have 2 players: aminoglycosides, which are bactericidal and blocking initiation and causing the ribosome to misread the code, and tetracyclines, which are bacteriostatic, blocking tRNA from binding. On the 50S subunit, we've got chloramphenicol and clindamycin, which block peptidyl transferase and translocation, plus the macrolides, all those drugs ending in thromycin and linezolid. These are mostly bacteriostatic, halting the growing protein chain. And here's the mnemonic that sorts every single one of them by AT30, C, EL at 50. The 30S drugs are aminoglycosides and tetracyclines, AT. The 50S drugs are chloramphenicol, clindamycin, erythromycin, and the macrolides and linezolid, CCEL. One line, and the whole family falls into place. Let's meet them individually. Let's spotlight the aminoglycosides, our bactericidal 30S blockers, because these are powerful, but they come with real baggage. Mechanism: they bind the 30S subunit, causing misreading and blocking initiation, and they are beautifully synergistic with beta-lactams. The two together hit harder than either alone. But here's a crucial quirk: they need oxygen to get inside the bacterium, which makes them useless against anaerobes. File that away, it's high yield. Now the toxicities you have to fear. Nephrotoxicity, usually reversible, thankfully. Ototoxicity, which is often permanent and gets worse when combined with loop diuretics. And they're teratogenic, so avoid them in pregnancy. The mnemonic ties it all together beautifully, mean GNETs, and they're not nice. GNATS gives you the drug names: gentamicin, neomycin, tobramycin, streptomycin. NOT gives you the toxicities: nephrotoxic, ototoxic, teratogen. And mean reminds you they're mean because they don't work without oxygen, no anaerobe coverage. Slick, right? Next up, two big 30S and 50S players, the tetracyclines and the macrolides. Let's take them together because you'll see them paired clinically all the time. Tetracyclines, the cyclines, doxycycline, minocycline, tetracycline. Their claim to fame is covering the atypicals, rickettsia, chlamydia, mycoplasma, and Lyme disease. Big caution: they bind multivalent cations, so tell patients to avoid taking them with milk, antacids, or iron, and avoid them in kids and pregnancy because they stain developing teeth and stunt bone growth, plus they cause photosensitivity. Macrolides, the thromycins: azithromycin, clarithromycin, erythromycin. Great for atypical pneumonia and for strep when your patient has a penicillin allergy. They bind the 50S, they're bacteriostatic, and importantly they're potent P4-5U inhibitors, so watch for drug interactions. Mnemonic for macrolide side effects: macro. Motility, meaning GI upset, arrhythmia from long QT, acute cholestatic hepatitis, rash, and eosinophilia. And don't forget that P4-5-DAZU inhibition. Macrolides are a magnet for drug interactions. Let's mop up the rest of the 50S blockers. Three drugs that are reserved and a little dangerous, but absolutely worth knowing: clindamycin, chloramphenicol, and linezolid. Clindamycin covers anaerobes above the diaphragm and is great for aspiration pneumonia, and it has this nice bonus of suppressing toxin production in necrotizing infections. The catch: it's a top cause of C. difficile colitis, so respect it. Chloramphenicol is broad spectrum and can be used for meningitis when options are scarce, but it's heavily reserved because of serious toxicity, aplastic anemia, and the dreaded gray baby syndrome in neonates. Linezolid is an oxazolidinone that covers the tough ones, MRSA and VRE, by blocking formation of the initiation complex. Watch for serotonin syndrome, since it's a weak MAO inhibitor, and thrombocytopenia. And here's your memory hook. These three share the PTS subunit with the macrolides. They're the CCEL half of by 8030, CCEL at 50. See how everything keeps connecting back to that one line. On to family number 3, the nucleic acid inhibitors. And the headliners are the fluoroquinones, the drugs that break the bacterial DNA machinery. Mechanism, they inhibit deanhydrase, which is topoisomerase S9. And topoisomerase 4, they are bactericidal with strong gram-negative and atypical coverage. You'll recognize them by the floxacin ending, ciprofloxacin, levofloxacin, moxifloxacin. These are workhorses for otitis, GI infections, and respiratory infections. But they come with a list of cautions you can't ignore. Their absorption is blocked by cations, so again, watch the antacids, iron and dairy. They cause tendon rupture and tendinitis, classically the Achilles tendon. They cause cartilage damage, so avoid them in kids and pregnancy. Add QT prolongation, phototoxicity, and CNS effects to the list. The mnemonic practically writes itself. Fluoroquinolones hurt your bones and tendons. Tendon rupture plus cartilage toxicity equals keep these away from children and pregnant patients. Easy to remember, easy to score. Family 4, the folate antagonists, and I love this slide because it's a story about teamwork. 2 drugs hitting one pathway in sequence. Bacteria have to build their own folate from scratch, and here's the assembly line. PABA gets converted by dihydroapterode synthase into dihydroapterode, then on dihydrofolate reductase turns DHF into THFF, which the bacteria need to make DNA bases. Now watch where our drugs strike. Sulfonamides block that first enzyme, dihydroapterode synthase. Trimethoprim blocks the later one, dihydrofolate reductase. Hit 2 enzymes in a row, that's TMP, SMX, and the combination is synergistic and bactericidal. We use it for otitis, PCP prophylaxis, and MRSA skin infections. Mnemonic for the sulfur cautions, think sulfur trouble. Skin reactions like Stevens-Johnson, urine crystals that are nephrotoxic, low folate causing megaloblastic anemia, failure in G6PD deficiency causing hemolysis, and avoid near term because of kernicterus. Trimethoprim adds its own twist, hyperkalemia and megaloblastic anemia, which you can rescue with folinic acid. 2 drugs, 1 pathway, total knockout. Let's talk about 4 special agents you absolutely cannot skip because they love to show up exactly when you've forgotten them. Metronidazole, nitrofurantoin, daptomycin, and the polymyxins. Metronidazole tackles anaerobes and protozoa by forming toxic free radicals inside the buck. Remember, it causes a disulfiram-like reaction with alcohol. No drinking on this one. Nitrofurantoin is first line for uncomplicated lower otitis, and it's safe in pregnancy, though you avoid it near term. Daptomycin disrupts the bacterial membrane and covers MRSA and VRE, but here's the classic trap. It gets inactivated by lung surfactants, so never use it for pneumonia and watch for raised CK and myopathy. Polymyxins are basically detergents that wreck gram-negative membranes. true last resort agents because they're nephrotoxic and neurotoxic, and the mnemonic for metrondazol's coverage: J38 Gapiu on the metro, Giardia intermoeba, Trichomonas, Gardnerella, anaerobes, and pylori, as in H. pylori, plus C. difficile. Pair that with the no alcohol rule, and you've got metrondazole down in one breath. Now for the antimicrobacterials, first line TB therapy, and this one has the cleanest mnemonic in all of pharmacology: RIPE, 4 drugs and you eat them all together. R is rifampin, which inhibits bacterial RNA polymerase. Its signature: it turns tears, sweat, and urine a red-orange color. Totally harmless, but I mean if nobody warned the patient, and it's a strong P450 inducer. I is isoniazid, which blocks mycalcalic acid synthesis. Watch for peripheral neuropathy, which we prevent by giving vitamin B6, and hepatotoxicity. P is pyrazinamide, active inside the acidic phagolysosomes, and it causes hyperuricemia. Think gout plus hepatotoxicity. E is ethambutol, which blocks arabinoyltransferase in the cell wall, and its classic toxicity is optic neuritis with red-green color loss. Mnemonic within the mnemonic: I-inch injures neurons and hepatocytes. Isoniazid gives you neuropathy. Prevent it with B6 and hepatotoxicity. And notice several of these ripe drugs are hepatotoxic, so you absolutely monitor liver function throughout treatment. Let's get clinical with a question you will face constantly: which antibiotics are safe in pregnancy and which ones you steer clear of? This is real-world bedside stuff. On the generally safe side, your reliable friends are the penicillins, cephalosporins, macrolides like azithromycin and erythromycin, clindamycin, metronidazole in the 2nd and the 3rd trimesters, and nitrofurantoin, though you avoid that one near term. Now the ones to avoid: tetracycline stain teeth and harm bone. Fluoroquinolones cause cartilage damage. Aminoleucosides cause fetal ototoxicity. Sulfonamides near term, risk kernicterus. Trimethoprim is an antifolate and teratogenic. And chloramphenicol causes gray baby syndrome. Here's your quick safe set mnemonic: penicillins, cephalosporins, erythromycin, and metronidazole. When in doubt in a pregnant patient, those 4 families are your reliable starting point. Memorize the safe list, and the rest is just process of elimination. Before we wrap, let's talk about the arms race, because bacteria are not sitting still. They fight back, and they've got 4 main strategies. Strategy 1: inactivate the drug using enzymes that destroy the antibiotic, like the beta-lactamases and aminoglycoside modifying enzymes. Strategy 2: alter the target, changing the binding site so the drug can't dock. That's altered. PBP is giving you MRSA and ribosomal methylation. Strategy 3: keep the drug out by losing porins or pumping the drug straight back out with efflux pumps. Reduced uptake plus active export. And strategy 4: bypass the pathway entirely using alternative enzymes or metabolic detours to route around the blocked step. And this leads to the most important clinical message of the whole lecture: stewardship matters. Right drug, right dose, right duration. Misuse breeds resistance, so we finish our courses and we reserve the big guns for when we truly need them. You are the front line against resistance. take that responsibility seriously. Alright, this is the slide you screenshot, the one-page recall, every mnemonic from this lecture in one place. Let me run through them so they're burned in. EC static for the bacteriostatic drugs, erythromycin, clindamycin, sulfonamides, tetracyclines, trimethylchloroprene, chloramphenicol. By AT30, CCEL at 50 sorts the protein synthesis inhibitors onto the right ribosomal subunit. Mean GNATS and not FOD, the aminoglycosides and their nephro, auto, and teratogen toxicity. Macro for the macrolide side effects. Not RED for vancomycin's toxicities, including red man syndrome. TCP for the antipseudomonal penicillin, ticasulin, carbonicillin, piperacillin. First gen equals PEC, Proteus, E. coli, Klebsiella. Loans, hurt bones for the fluoroquinolone, tendon and cartilage risk. GTGA upon the metro for metronozole's coverage. And ripe for first-line TB, rifampin, isoniazid, pyrazinamide, ethambutol. Pause the video right here, take a screenshot, and make this your night before the exam cheat sheet. Let the phrases do the heavy lifting for you. And that's a wrap. Let me leave you with 5 big ideas to carry into the wards, because if you forget the details, these 5 will keep you grounded. 1. Always start with the mechanism. Place every drug on one of the 5 targets and its behavior simply follows. 2. Cidal or static shapes your therapy. Choose cidal when the host can't help itself, endocarditis, meningitis, neutropenia. 3. Toxicities define the boundaries. The aminoglycosides, vancomycin, fluoroquinolones, and sulfur drugs each carry a signature warning. Know them cold. 4. Pregnancy and kids narrow the menu. Reach for penicillins and cephalosporins. Avoid tetracyclines and fluoroquinolones. And 5. Mnemonics make recall reflexive EC stati, G8, macro ripe. Let those phrases do the heavy lifting under exam pressure. If this video helped it all click, do me a favor and like, subscribe, and drop a comment with the mnemonic that saved you. Study hard, be kind to your patients, and I'll see you in the next lecture. You've got this.